Hello once again, ladies and gentlemen, and welcome to part 2 of our psychiatry review questions. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right hand corner. I appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you very, very much who have already donated. All right, let's go ahead and start. Okay, question 1. A 23-year-old man presents to the clinic for a follow-up 2 weeks after being diagnosed with major depressive disorder. He had been experiencing depressed mood, insomnia, difficulty concentrating in class, feelings of worthlessness and guilt, and a loss of interest in activities he used to enjoy. He was prescribed escitalopram 10 milligrams daily. Today, he says that for the past 5 days, he's felt much better. He's able to study all night and sleeps 3 to 5 hours each night. He's been working on his thesis that he's convinced will earn him a Nobel Prize. He conveys his gratitude for your help. He says he signed up for 2 extra classes for the upcoming semester so he can take the following semester off this autumn to travel the world, which he just paid for. He works part-time as a teaching assistant. He's a graduate student. He does not smoke, drink alcohol, or use recreational drugs. Vitals are within normal limits. Physical exam is unremarkable. Thought process is tangential. Content is delusional and grandiose. Speech is pressured, and he fidgets in his chair, asks questions about the sign on the walls, and what the medical equipment on the table is for. He then asks how long this appointment will last. He tells you, "My thesis can't wait. I have lives to save." Urine drug screen is negative. Which of the following is the best next step in the management of this patient? A. Discontinue escitalopram. B. Reduce dose of escitalopram to 5 milligrams daily. C. Add clonazepam. D. Add lithium. E. Add valproic acid. Or F. Admit for psychiatric hospitalization. Okay, so the next question will be a follow-up, so lock your answer in here. The appropriate adjustment is medication regimen is completed. 1 week later, the patient is brought into the ED by law enforcement who say that the patient had broken in to one of the laboratories at 3 a.m. without authorization. The patient says, "I needed to synthesize chemicals so I could create the cure for cancer I devised. It's going to save the world." The patient is admitted to the psychiatric unit. He started on lithium and is titrated to 1.2 milliequivalents per liter, the therapeutic window being 0.6 to 1.2. 3 days later, review of nursing notes indicate that he continues to roam the unit, making inappropriate advances on staff, is starting arguments with other patients, and is sleeping only 3 hours per night. Vitals are within normal limits. His speech is pressured, thought process tangential, thought content delusional and grandiose. He asks you how much longer he's going to be hospitalized and says, "Every hour I'm here, people are dying without my cure for cancer." Which of the following is the best next step in the management of this patient? A. Increase lithium dosage. B. Discontinue lithium and start lamotrigine. C. Discontinue lithium and start a second-generation antipsychotic. D. Add a second-generation antipsychotic. Or E. Add a benzodiazepine. All right, so we're going to go back and we're going to answer question 1. So, for question 1, the answer is to discontinue escitalopram. Why? It seems to be working. He was depressed, he took the escitalopram, and now clearly he feels better. Well, not so much. This guy is not going to be able to function. Okay, first of all, he's delusional. Do you think a 23-year-old guy on his own is going to devise the cure for cancer and get a Nobel Prize? Heck no. That is a delusion of grandeur. Okay, so we already are looking down the barrel of a manic or hypomanic episode. So what are our criteria for mania? Remember, dig fast. Distractibility. What's I? Impulsivity. What's G? Grandiosity. How about F? Flight of ideas. A, activity increased. S, sleep deficit. And we're not talking about people who are going to be tired and not able to concentrate because of that. We're talking about people who literally require less sleep, or so they think. And T is talkativity. That's the pressured speech. Okay, that's where you're talking really fast. You're saying a lot, but maybe it's not making sense. Okay, so what does he have here? Is he distracted? Yeah, he's asking about signs on the wall, what medical equipment is for. That is not relevant to why he's there. So we got that. Impulsivity. Yes. He just paid for a trip around the world. He's a student. Do you think he's got the money for that? No. He might, but I mean, considering that this is in conjunction with other manic symptoms, we could probably call this impulsive. Grandiose? Yeah, he thinks he's going to get a Nobel Prize. Flight of ideas, we don't really see that here. So he might have that, but that's not here. So that's out. Increased activity? Yes. Okay, he's going to be signing up for 2 extra classes. He's up 3 to 5 hours, or he's only sleeping 3 to 5 hours a night. He's working on his thesis. You might go into asking him how many hours are you working on that thesis, but this is likely an increase of activities. Sleep deficit, yes. Talkativity, yes. He's got 6. How many do you need for a diagnosis of mania or hypomania? Well, you need 3, but you actually will need 4 if they have an irritable mood. We don't see that here. And so we really only need 3. We got 6. So this is a hypomanic or manic episode. Which is it, hypomanic or manic? It is probably hypomanic right now, because hypomanic episodes are not severe enough to cause impairment. There's no psychotic features. And when I say causing impairment, I'm talking about an inability to function. I'm talking about getting into legal problems, stuff like that. So this is a guy who is able to function, but he is having manic features. So this is probably hypomania that he's in. Okay, so what you will often see when you diagnose a patient with major depression, you put them on an SSRI or some kind of antidepressant, you could precipitate a manic episode. And when you have a patient who has developed a manic episode, whether that's in conjunction with an SSRI or not, they will always be bipolar. Okay, if you have had one hypomanic or manic episode in your entire life, even if it's 30 years ago and you have a depressed mood, we are treating you for bipolar. We will never treat you for depression. You are disqualified from major depression. You are disqualified from SSRIs. It's always going to be treatment for bipolar disorder, okay? That's very, very important, because you may get a question. They say 30 years ago, I had a hypomanic episode, was diagnosed with a hypomanic episode, and now they're major depression. No, it's not major depression. It's going to be bipolar, probably bipolar 2 if it was a hypomanic episode, okay? So that is very, very, very important, because the treatment is different. If you misdiagnose a patient with bipolar and label them major depressive and give them an SSRI, you could get into trouble. You could precipitate a manic episode. And that's, in fact, what happened here. Perhaps the patient never had a hypomanic or manic episode in the past, but when an SSRI was given, it precipitated that. And that's fairly common. Okay, so we need to discontinue the SSRI, and that's why A is the correct answer. Reduce the dose? No, it needs to be discontinued. Clonazepam probably isn't going to be very effective here, because we don't treat manic episodes with benzodiazepines. If anything, we would use an antipsychotic. How about lithium? No, that would take too long. You could do lithium, but you have to discontinue the escitalopram. That is our number one priority, because that's what's probably behind this manic episode. And does he need psychiatric hospitalization? Typically, a psychiatric hospitalization is when the patient is a danger to themselves or others. And by danger to themselves, we're not just talking about self-harm. We're talking about anything that could get them into real trouble. So if they're getting into legal trouble, for instance, if they have no insight, if they're unable to function, that would be certainly if it's an actual manic episode rather than a hypomanic episode. Typically, those patients are going to need to be hospitalized. Okay, so that's not it. So the answer is A. Now, for question 2, the answer is D. Add an antipsychotic. Why? This is a manic episode. Okay, he's got all the same symptoms he had when you started. And now he's breaking into laboratories. He's getting brought in by law enforcement. This is a patient that needs to be hospitalized. Okay, at this point, he has to be hospitalized. Even though he doesn't have a threat of harm to himself or others, he's getting into legal problems, and that's an indication for hospitalization. So you hospitalize him, we've done that, and we put him on lithium, and he's continuing to have these problems. What we then need to do is add an antipsychotic. And that could be a first generation or a second generation, but we prefer to do a second generation, and that is going to be in conjunction with the lithium, okay, in conjunction. So increase lithium dosage? No, he's at the upper limit for the therapeutic window. Discontinue lithium? No, we want to keep him on lithium. That's going to be probably his maintenance. So we need to continue the lithium and then add a benzodiazepine. That's not going to help. That's just going to make him tired. When it wears off, he's going to go back to manic. Okay, so we need to add a second generation antipsychotic, like Abilify. Okay, fairly nice drug. Doesn't have a whole lot of side effects. Okay, so that's what we need to do. So here's mania. We talked about that. Manic episodes versus hypomanic episodes. Really, the difference is whether it's severe enough for hospitalization, causes market impairment or not. And certainly if there's psychotic features, regardless of whether there's market impairment, then it is a manic episode. Although if you have psychotic features, that's typically going to cause some impairment, okay? So bipolar 1 and bipolar 2, basically all these patients are going to have depressive episodes. If it's a manic episode, it's bipolar 1. If it's a hypomanic episode, it's bipolar 2. Most patients with bipolar are bipolar 2, but you do run into bipolar 1. If they're in the hospital, if they're hospitalized because of their manic episode, then they are bipolar 1. Okay, so basically all the patients you're going to, well, let me rephrase that. All the patients who come in with bipolar that have to be hospitalized and they're having a manic episode, that's going to be bipolar 1. If you have a patient who's had a hypomanic episode and they have to be hospitalized for a depressive episode right now, then it could be bipolar 2. Okay, so for bipolar 1, for an actual manic episode, they need to be hospitalized for the manic episode, not for a depressive episode. Cyclothymic disorder is where you have, this is going on for a long time. They don't meet the criteria for a hypomanic episode, and they don't meet the criteria for major depression, but they've got some fluctuating manic symptoms, but not reaching the criteria. They've got some mild depressive symptoms, but not meeting the criteria for major depression. This is going to be kind of your diagnosis of exclusion. Major depression, mania, bipolar, that always takes precedence over anything else. Almost. Okay, so let's move on to 3. A 50-year-old woman presents to the clinic. She says, I've been a nervous wreck for the past few weeks. Last month, she underwent surgery for ductal carcinoma in situ, which was diagnosed on routine mammography. The surgery was successful, and the surgeon told her that she has an excellent prognosis and should follow up with annual mammograms as recommended. Despite this, she says that she's felt down and has difficulty sleeping because she's afraid her breast cancer is going to come back. She says sometimes she stays up all night researching breast cancer and says, it's all I think about. She continues to be involved in her yoga group and family activities. She says, I'm more tired than usual, but I have enough energy to get through the day and function at work as long as I sleep extra on the weekends. Her appetite is unchanged, but she occasionally devours 3 slices of cake in one sitting, and she did this before she got the cancer diagnosis. She denies feelings of guilt and vehemently denies thoughts of self-harm. She has no significant past medical history and takes no medications. Vitals are within normal limits. Physical exam reveals a well-healing surgical incision on the left breast. Otherwise, the physical is unremarkable. Which of the following is the most likely diagnosis in this patient? A, major depressive disorder, B, generalized anxiety disorder, C, adjustment disorder, D, illness anxiety disorder, or E, normal stress response. Okay, Let's go on to our answer. This is a patient with adjustment disorder. So typically what an adjustment disorder is going to be is a patient who is in distress after a stressor, but they don't meet the criteria for another disorder. If she had, she's tired, she feels guilty that this breast cancer diagnosis was causing distress for her kids. She didn't have energy. She's not eating. She's having thoughts of self-harm. Then you would diagnose major depression. So adjustment disorder is something you would diagnose if depression isn't met, if anxiety isn't met. We don't see any of that. She does have some anxiety, but it is anxiety related to a stressor. Okay, so she doesn't fit the criteria for generalized anxiety. She has anxiety as a symptom, but it is related to the stressor being her diagnosis of carcinoma in situ. Now, is it normal to have a little anxiety? Sure. But this is anxiety that is causing her problems. She's staying up all night. We can't have that. Okay, so this is adjustment disorder. It is not adjustment disorder with depressed mood because she is not depressed. You could maybe call it an adjustment disorder with anxious mood, but I don't know if that's actually an entity. But she's not depressed mood. Okay, so this is just adjustment disorder. Why not major depressive disorder? She doesn't meet the criteria. Same with generalized anxiety. Illness anxiety disorder, that's when you're worried you have an illness that you don't have. Okay, she had breast cancer. Okay, so the anxiety is not that she's got breast cancer, but she doesn't have it. The anxiety is that it might come back. That is not illness anxiety disorder, okay? Normal stress response, no, this is not normal. Normal stress responses are not excessive, not out of proportion to the severity of the stressor. She had ductal carcinoma in situ. If that is removed, what is the survival? 100%, okay? So this is out of proportion, and with a normal stress response, there's no significant functional impairment. She's staying up all night. That is inevitably going to cause some degree of functional impairment. So here's what we talked about: major depressive disorder, persistent depressive disorder, which is basically where they don't meet the major depressive disorder criteria, and it goes on for a very long time. We talked about adjustment disorder, and we talked about normal stress response. Okay, question 4. A 14-year-old boy presents to the clinic with his mother, who says the patient has been anxious for the past several months. She tells you he's always been a shy boy and prefers to do things by himself. He's often awkward with other children and extended family members, which makes it difficult to socialize as he has difficulty understanding jokes and sometimes responds defensively. He is able to answer questions appropriately, but speaks very softly and monotonously and does not engage in spontaneous conversation. When you ask him about his mood, he says he loves watching baseball and tells you several players' batting average and other statistics. He then tells you details about how the sport developed and how different pitches should be thrown to batters based on their handedness and hitting style. His mother says he has loved baseball since he was 5 and eats hot dogs every night because it reminds him of baseball, and he gets very upset if he has anything else to eat for dinner. He has no significant past medical history. Vitals are within normal limits. Thought process and content are linear and normal. He looks out the window while speaking. Physical exam is unremarkable. Which of the following is the most likely diagnosis in this patient? A, generalized anxiety disorder. B, social anxiety disorder. C, obsessive compulsive personality disorder. D, schizoid personality disorder. E, schizotypal personality disorder. Or F, autism spectrum disorder. Okay, well, this is kind of a tough one. Go on to our answer. So this is a kid with autism, all right? Autism typically is going to start very early in life. This is something that you will notice. Now, see this? He's always been a shy boy. Now, is that enough for autism? Absolutely not. However, when you put it together with these other things, he's not engaging in spontaneous conversation. He has difficulty understanding jokes. Social cues are a problem for people with autism, okay? They have difficulty sharing their emotions. They have difficulty with nonverbal communication. They often don't make eye contact. They have difficulty understanding metaphors, difficulty understanding sarcasm, difficulty developing relationships. And then we see this stuff with baseball. This is a fixation, okay? This is a fixation. Now, is it normal to have interests? Yes, but when you're talking about memorizing batting averages, getting upset if you don't get to have your baseball-style hot dogs every night, that is a fixation, okay? So what we're looking at here is autism spectrum disorder. Generalized anxiety? No, he's not anxious. Social anxiety, well, he doesn't really interact with people, but there's nothing to indicate that he wants to interact with people and is just nervous. And I apologize, my German Shepherd is whining outside my door. So it's not social anxiety. Obsessive compulsive personality, no, that's the control freak. He's not that. Schizoid personality disorder, well, he does isolate a little bit, but with any personality disorder, you cannot meet the criteria for something like autism or depression or anxiety. So that's out. Schizotypal, that's odd beliefs. That's your eccentric person. It's not that. So this is autism. We talked about this a little bit. So they need to have social deficits. It's got to come on very early in life. This isn't something you're going to be diagnosed with when you're 25 years old. Difficulty sharing emotions, difficulty with nonverbal communication, difficulty establishing relationships. A lot of times these patients don't care. They don't want to develop relationships. Sometimes, but most of the time they don't. They're happy with their fixations, being by themselves. Restrictive and repetitive behaviors and interests, you can probably figure out what that means. These fixated interests, insistence on the sameness and routines. They don't like deviating, so this kid liked to have hot dogs every night. He's got to have his hot dogs every night, and if he doesn't get it, well, look, he gets very upset. That is typical for a person with autism. And then we sometimes see these adverse responses to sensory input and then language delays and cognitive impairment. This is kind of as we go down here. These symptoms are indicative of more severe autism. For evaluation, you want to do a comprehensive clinical examination. Genetic testing, autism can be associated with congenital abnormalities, and then plus or minus a brain MRI. The treatment here is individualized, really just maximizing their function. A lot of people with autism can function normally. Some can't. That's why they call it autism spectrum disorder. It's a variety of severities. All right, question 5. A 44-year-old man presents to the clinic for his annual routine exam. Last year, you had a discussion with him about smoking cessation. At that point, he was smoking 1.5 packs of cigarettes per day. He agreed to begin nicotine replacement therapy. My dog's going nuts. And has been using nicotine patches since then. He says that although his cravings have decreased and he now smokes only a half pack per day, he wants to stop smoking completely. He has no significant past medical history and is on no medications. He doesn't drink alcohol and occasionally uses cannabis recreationally, but uses no other recreational drugs. Vitals are within normal limits. BMI is 24.9. You discuss beginning varenicline, and he is very receptive to the idea of using pharmacotherapy. Which of the following is the most likely adverse effect from this medication? A, sleep disturbances, B, weight gain, C, seizures, D, hypertension, E, angina, or F, increased risk of suicide. Okay, so go ahead and pause if you want. We're going to go on to the answer. All right, so the answer is sleep disturbances. Now, if you went to medical school prior to 2016, maybe you're taking USMLE from another country, you might think varenicline, suicidality. Used to have a black box warning that was taken off in 2016. Okay, so that is no longer there. Weight gain, what would we see with that? Well, actually, really none of these. Weight gain could be an adverse effect of stopping smoking, of nicotine withdrawal. Seizures, well, bupropion, okay? Seizures. It can lower the seizure threshold, and therefore it is contraindicated in patients with seizure disorders. Hypertension? No. That can be worsened by bupropion, though, if they have a pre-existing hypertensive disorder. Angina, no. Okay, so sleep disturbances. So for smoking cessation, you have a number of options. Varenicline is the most effective therapy. The only major adverse effects from that is sleep disturbances and abnormal dreams. Some patients can tolerate this really well. Other patients really can't. Those patients tend to have psychiatric histories. There's nicotine replacement therapy. This can be obtained over the counter. Many patients will try this before they come in. So this does reduce cravings. You can combine both short-acting and long-acting, so you can take the gum and the patches. That's totally fine. Really no adverse effects with this or contraindications. That's why it's over the counter. Bupropion, this is actually a really nice drug to use if the patient wants to quit smoking and they have depressive symptoms as well. Okay, so it works. It would work for both. Two birds, one stone. This also is weight neutral and actually can cause weight loss. So, you tailor it to the patient, but what you want to remember is varenicline is the most effective therapy, and you can use that in combination with other drugs. You can use that in combination with nicotine gum or nicotine patches. All right, but eventually you want to go off these things. Okay, question 6. We have a 30-year-old woman presenting to the clinic complaining of difficulty concentrating at work. This has been a problem for the past couple years, and she thinks it's related to her sleep. She's tried melatonin, diphenhydramine, and has even bought a new mattress, but she continues to struggle falling asleep. She's kept a sleep diary for the past month as she read online that physicians prefer this before treating sleep issues, and she's right. On weekdays, she usually goes to sleep at 11 p.m. and wakes up at 5 a.m. to go to work. On weekends, she usually goes to sleep around 10 p.m. and sleeps till 9 a.m. During the day, she drinks 3 to 5 cups of coffee in the morning to help her concentrate. Her boyfriend is with her and says she's frequently irritable when she gets home during the week, but she's better during the weekends. She has a past medical history of major depressive disorder, but stopped medication 5 years ago. She doesn't smoke or use recreational drugs. She drinks 1 to 2 alcoholic beverages weekly, always on the weekends. Vitals are within normal limits. She's gained 10 pounds since her last visit 1 year ago. Physical exam is unremarkable. Which of the following is the best next step in the management of this patient? A, recommend a constant sleep-wake schedule. B, abstain from all caffeine intake. C, abstain from alcohol. D, polysomnography. Or E, methylphenidate. Okay, so let's go on to our answer. Recommend a constant sleep-wake schedule. This is a patient with disordered sleep. This is a patient with insomnia, chronic insomnia. It's been going on for the past couple of years. All right, so this is insomnia. The difficulty concentrating at work, sure, that can be associated with. I am so sorry for this. Difficulty concentrating at work can be related to depression, but she has no other features of depression. ADHD, so E, methylphenidate. Well, difficulty concentrating has to be in more than one setting. Okay, so we don't see it anywhere else, so that's out. Abstain from all caffeine intake. No, you don't need to do that. But she's drinking 3 to 5 cups in the morning and the afternoon. You want to stop drinking coffee. Oh my God, I'm so sorry. You want to stop drinking coffee 8 hours before bed. Most people go to bed. Well, she goes to bed at 11 p.m. 3 p.m. Oh, I'm so sorry. 3 p.m. You would want to stop. So you would probably tell her, drink your coffee in the morning and then try to abstain in the afternoon. But you don't need to abstain completely. Abstain from alcohol. Well, she's only drinking alcohol on the weekends. She's having difficulty with sleep during the week too, so that's not going to help. Polysomnography, that would be something to do if she's getting 8 hours of sleep per night and she's still tired during the day. All right, so the answer is A. All right, so here's your behavioral modifications for chronic insomnia. We're always going to go to behavioral modifications first before we go to sleep aids. So this is really something the patient can do on their own. Establish a constant daily wake time. Wake up at the same time every morning. So if she's waking up at 5 a.m. for work, wake up at 5 a.m., maybe 6 a.m., that might be okay. But 5 a.m., try to aim for that on the weekends too. Optimize the quantity and timing of caffeine intake. We talked about that. Optimize quantity and timing of alcoholic beverages, particularly on the days where you have to wake up. Remember, alcohol reduces REM sleep. Limit time spent awake in bed. Bed is for sleep and sex. Don't read in bed. Don't watch TV in bed. Don't eat in bed. You want to get your brain associating the bed with sleep. Cognitive behavioral therapy can be used for insomnia. If behavioral therapy is ineffective, then we can go to pharmacotherapy as an adjunct, zopiclone, zolpidem, things like that. Okay, so I let my dog into my office. Hopefully he is quieter. He is curled up on his bed now, so let's hope for the best. He is an 8-month-old German Shepherd, so he's still in the whiny phase. All right, so let's take a look at this patient. This is a real patient that I saw not too long ago. A 23-year-old man presents to the clinic for follow-up after an ED visit 2 weeks ago after having been found with an empty pill bottle of vitamin B12 tablets and a suicide note left up on social media. This was precipitated after his boyfriend of 2 months broke up with him. He says he feels fine now and that his boyfriend was a jerk, and I'm glad he's out of my life. He's now dating another man that he met on Tinder, and he's great. He's going to be my husband someday. He was diagnosed with major depressive disorder 6 months ago and prescribed sertraline, but quit taking the medication after 3 months because it wasn't helping. He says he often feels dead inside, and sometimes I feel like there's nothing inside of me. Last week, he drank 2 bottles of wine and drove 10 miles to his sister's house because he punched a hole in the wall at his mom's house where he lives, and she told him to get out. He has since moved back in. His mother, who's with him, says he frequently gets angry, but he's otherwise a good kid. He has no significant past medical history. He works as a special ed aide at a local elementary school and was recently nominated as Teacher of the Month. He does not smoke or use recreational drugs, but he says he binge drinks when he feels down. He says that he struggles to sleep at night. Vitals are within normal limits. He has lost 5 pounds since his last visit 6 months ago because he hasn't been hungry lately. On physical exam, you note linear scars on his wrists bilaterally. Remainder of the exam is unremarkable. Which of the following is the most likely diagnosis in this patient? A, major depressive disorder, B, bipolar 2 disorder, C, intermittent explosive disorder, D, borderline personality disorder, or E, alcohol use disorder. So lock in your answer here, and we will move on to a follow-up question. Which of the following is the best next step in the management of this patient? A, sertraline, B, lithium, C, referral to outpatient substance abuse treatment center, D, bupropion, E, dialectical behavioral therapy, F, interpersonal psychotherapy, G, haloperidol, or H, aripiprazole. So lock in your answer. And let's go and talk about the diagnosis here. So this kid has got borderline personality disorder. Now, anytime you diagnose a personality disorder, you must make sure they don't have a mood disorder, they don't have an anxiety disorder, they don't have a psychotic disorder, because that will always take precedence over the personality disorder. Now, can you have a mood disorder superimposed on a personality disorder? Can you have an anxiety disorder superimposed on a personality disorder? Absolutely. However, when they're asking you one versus the other, major depressive disorder versus borderline personality disorder, you need to know that that depression, bipolar, that's always going to take precedence over the personality disorder with regards to the diagnosis. Likely, if they have major depression, they won't ask you about the personality disorder, or they won't give you a personality disorder. That starts to get a little bit complex. But just know, mood disorders, anxiety disorders, psychotic disorders, PTSD, that always takes precedence over the personality disorders. So, why not major depressive disorder? Okay, so there's a suicidality, there's difficulty sleeping, and there's a loss of appetite. That is 3. How many do you need? 4 or more. You need 4 or more of those criteria. Okay, so he doesn't have that. Bipolar 2, there's no mania here. Was irritable, but that's about it. Intermittent explosive disorder. He's got all sorts of other symptoms. Okay, intermittent explosive disorder, you can't have mood disorder, you can't have anything like that. Intermittent explosive disorder is purely, where did I write it? This. Okay, anger, these sudden anger episodes. He's only done this once, so that's not enough to diagnose intermittent explosive disorder. I've kicked holes in the wall, not because I was angry at anyone, but because, I'm a Minnesota Vikings fan. So if you know anything about that, you know exactly what I mean. That's out. Alcohol use disorder. Well, yeah, okay, he binge drinks once in a while, but he's not addicted. He doesn't have withdrawal symptoms. Clearly, he's functioning at work, so that's not it. So this is just borderline personality disorder. What's the treatment for borderline personality disorder? It is psychotherapy, specifically dialectical behavioral therapy. Interpersonal psychotherapy, could help, but that's more for depression and anxiety. Sertraline, that's treatment for depression. He doesn't have that. Lithium, that's treatment for bipolar. He doesn't have that. Referral to outpatient substance abuse treatment center. He doesn't have substance abuse. Bupropion, that is for depression. That's out. Haloperidol, aripiprazole, we would give him this if he was actively agitated or psychotic. Those are both out, okay? So borderline personality disorder. These are patients, you'll know them when you see them, okay? You can memorize these, but you should just have the general idea of what a person with borderline personality has. So you can look at these criteria. Frantic efforts to avoid abandonment. So if they start to get in an argument with their significant other, they may really start freaking out. Or let's say their significant other doesn't text them for 3 hours, delays response, they start to get anxious, they start to feel empty. That's the frantic efforts to avoid abandonment. These are the kinds of people that you're dating them and you don't respond and they send you like 15 text messages. That's very indicative. Markedly and persistently unstable self-image. Their self-esteem bounces back and forth. Impulsivity in 2 areas that are potentially self-damaging. Where do we see that in this patient? He drank 2 bottles of wine and drove 10 miles. That is impulsive. That is dangerous. Okay, drunk driving. So he met that. Recurrent suicidal behaviors and or threats of self-mutilation. People with borderline personality tend to threaten suicide more than they try it. Okay, he took a bottle of pills, but he took vitamin B12 tablets. Is that going to kill you? Absolutely not. However, I'm going to tell you this right now. You got a patient who takes a bottle of pills. We don't know if they know that can kill you or not. Okay, you take a bottle of vitamin C tablets and they leave a suicide note, you're treating that as a suicide attempt. Okay, just as much as if they took a bottle of benzodiazepines or they took a bottle of aspirin. Okay, so it doesn't matter if they take a bottle of pills and leave a suicide note, you're treating that just the same as if they took a bottle of benzos or they took a bottle of aspirin or they took a bottle of NSAIDs. Mood instability, we kind of talked about that. Chronic feelings of emptiness, well, here you got it right here. It feels dead inside. Feels like there's nothing inside of me. Inappropriate and intense anger, punch the hole in the wall. Transient stress-related paranoia or dissociation, that's a little bit less common, but these patients with borderline personality disorder can have psychosis. Okay, so another thing that we see here in this patient is something called splitting. Okay, and what is splitting? Splitting is where you see the world in black and white, okay? So these patients may come in and they talk to you and they say, oh, you are the best doctor I've ever had. My last doctor was a complete jackass, okay? That is splitting. They don't see in between. You're either bad or you're good. Just like this guy, okay? His boyfriend broke up with him, and also, it was only 2 months, okay? So this is a really big response, and that is common. They have strong emotions, these people. And it was the end of the world. He tried to hurt himself. And now, just a couple weeks later, he's dating somebody completely different, and he's convinced that they're going to be in a long-term relationship. So the ex-boyfriend was a jerk. This guy is great, and these feelings are so intense that he thinks they're going to be together forever. That is so classic for borderline splitting. Okay, know that. It's not a diagnostic criteria, but it's something you see often. And then one more thing that you see very, very often in bipolar disorder, borderline personality disorder is cutting, okay, self-harm. And it's not the kind of self-harm that's going to kill you. It's the kind of self-harm that tends to draw attention. However, what I have heard personally from people with borderline personality disorder is they cut themselves so they can feel something. And that might relate to those empty feelings, okay? Now, the treatment for borderline personality, which, by the way, is very difficult to treat, the treatment, though, is dialectical behavioral therapy. Marsha Linehan did a really, really, really big service to the psychiatric community by developing this dialectical behavioral therapy. You don't need to know what that is. You're not going to school to be a therapist, but you do need to know that it is the best management for borderline personality disorder. Typically, with these personality disorders, they're very recalcitrant. They're not going to go away completely, but you can help them manage it. If they have a comorbid mood or anxiety disorder, like which I said could happen, then you will give antidepressants. If they have a comorbid bipolar disorder, you would give them lithium. Just treat the comorbid disorders as you would with anybody else. Adjunctive pharmacotherapy for mood disturbances and transient psychosis. If you're dealing with a patient with transient psychosis with borderline personality disorder, once again, you're going to treat them just like everybody else. So if they're coming in agitated, they're coming in hallucinating, they're coming in something like that, yes, Haldol, go for it. Question 9. A 50-year-old woman presents to the clinic complaining of feeling down for the past 5 weeks. She says that she's never felt like this before, and this all started when my daughter moved off to go to college. She's the only person who lived with me, and now I feel alone. She works as an accountant and says that since these feelings started, she's had difficulty paying attention at work, but she's able to function. She sleeps 6 hours a week on weekdays and 7 to 8 hours on the weekends, and says that she has difficulty falling asleep because she's worried about her daughter. She says, my daughter doesn't call often, and it's probably because she wanted to get out, and I've never been the kind of mom I wish I could have been because I work all the time. She had been active with a book club, which she hosts at her house, but she put that on hiatus because she's too tired and doesn't care about reading anymore. She denies suicidal ideation. She doesn't smoke, drink alcohol, or use drugs. She has no significant past medical history and is on no medications. Vitals are within normal limits. Physical exam is unremarkable. She's well-groomed and polite. Affect is flat. When discussing treatment options, which of the following is the best statement to make to this patient, or best question, I guess? A, how you're feeling is normal. You have adjustment disorder and you will begin to feel better with time. Have you considered seeing a therapist? B, how has your appetite been? C, would you be interested in starting a medication? If that doesn't work, we can refer you to a therapist. D, would you be interested in seeing a therapist? E, would you be interested in starting a medication and seeing a therapist? Or F, would you be interested in attending an outpatient therapy group? Okay, so go ahead and lock in your answer here. This is just one question, standalone. All right, so this is a patient with major depressive disorder. Now, a lot of times you think, oh, something happens, their mood is depressed. Life change, mood is depressed. Must be an adjustment disorder. No, no, no. Major depressive disorder takes precedence over pretty much anything except schizoaffective disorder. Okay, so yes, it could be adjustment disorder, but if they meet the criteria for major depressive disorder, it has to be major depressive disorder. Okay, she's feeling down. All right, depressed mood, difficulty paying attention. There's your C in the SIGI caps. Let's see, difficulty falling asleep. There's the sleep disturbances. I've never been the kind of mom I wish I could have been because I work all the time. What is that? That's guilt. Okay. She's too tired. That's a loss of energy. Doesn't care about reading anymore. That's anhedonia, loss of interest. Okay, so let's go ahead and look. She had the sleep disturbances. She had the loss of interest. She has the guilt. She has the energy, concentration impairment, appetite changes or change in weight. Let's see. I want to make sure I didn't miss that. Nope, none of that. Psychomotor, no. Suicide, no. She's got 5. You only need 4. 2-week period. It's been 5 weeks. She meets the criteria for major depressive disorder. It needs to cause significant distress or impairment. That's not a really high bar. If you're talking about not being able to get to sleep, you're distressed. Distress, that again, not a high bar. This is a woman who's despondent. It's getting in the way of her ability to do what she likes to do. So that is distress. Not related to a substance or medical condition. As far as we know, she's not on any substances. Not better explained by a psychotic disorder. She doesn't have psychosis. No history of manic episodes. She doesn't have that as far as we know. If it doesn't tell you anything, just assume it's not there. All right. Now, that being said, we need to make sure that this isn't something else. Okay. So again, like I've said, general principle of psychiatry, if a patient comes in, you think they're depressed, you still need to get a TSH and sometimes a urine drug screen, particularly if they're manic or psychotic. You wouldn't need to do that with this patient, but it would be helpful to get a TSH. She's a middle-aged woman. They can get, Hashimoto's and stuff like that. So it's possible. But this is most likely major depressive disorder. The management is cognitive behavioral therapy and or pharmacotherapy, but combination therapy is the most effective. And so we want her to start a medication and see a therapist. Now, can they do one or the other? Sure. Some patients don't want to go on drugs and they're happy just seeing a therapist. That is okay. It is effective. Some patients can't afford to see a therapist. Maybe their insurance doesn't cover it. Maybe you're in a country where you have national health insurance and it doesn't cover counseling. So you can do one or the other, but ideally both. SSRIs are first line. Okay, now does that mean you have to do an SSRI? No, you can do an SNRI, you can do an NRTI. They're all more or less equivalent. Psychiatrists will be the ones to make the decision on what is better, but for your purposes, SSRI is the one you'll go to. All right, let's finish up with question 10. We've moved through these fairly quickly. A 28-year-old man presents to the clinic complaining of body aches for the past 2 weeks. He says that he's also had difficulty sleeping, waking up several times at night, and this has been going on since he immigrated to the United States from Ukraine 3 months ago, immediately after spending 1.5 years on the front lines in the war, which he says that he doesn't want to talk about. His friend gave him 5 tablets of oxycodone last month, and he says this helped his body aches. He says that ever since leaving Ukraine, he's had marital problems and he drinks 1 to 2 alcoholic beverages every evening. He says, I thought moving to the U.S. would help me get a new start, but I don't feel any better. He's been unable to find work and feels guilty that his wife is the sole provider for him and their 6-year-old daughter. He says that his appetite is normal and he's been applying for jobs, but when he gets turned down, he occasionally yells at his wife. He enjoys gardening at home and proudly shows you the flowers he's growing and is looking forward to harvesting apples from the tree in his backyard. He doesn't smoke or use recreational drugs. He's got no other complaints. He's requesting oxycodone to help with his body aches. Vitals are within normal limits. Physical exams unremarkable. Which of the following is the best next step in the management of this patient? A, prescribe oxycodone. B, sertraline referral for psychotherapy. C, screen for post-traumatic stress disorder. D, screen for alcohol use disorder. E, prescribe zopiclone. Or F, provide information about social support programs for veterans. All right. So this is a little bit more of a step 3 question, but step 2, it's good to know it for that too. Okay. So the answer is to screen for post-traumatic stress disorder. Anytime you've got a veteran with psychiatric symptoms, always screen for PTSD. Now, if he meets the criteria for a mood disorder, for a psychotic disorder, for an anxiety disorder, we'll treat that. But this guy doesn't meet the criteria for anything. So here I highlighted in pink the major depressive symptoms, difficulty sleeping, and guilt. That's it. That's only 2. Okay, you need 4 or more. So it's not major depression, so there goes the sertraline. Prescribe oxycodone? Absolutely not. He's got body aches, all right? We may want to get to the bottom of that, but prescribing narcotics for somebody with vague complaints is not the way to go. Screen for alcohol use disorder. All right, so he's drinking 1 to 2 alcoholic beverages every evening. Is that a lot? No, that's actually... we don't really consider that abnormal. 1 to 2, not a problem. He's also fairly able to function. He's applying to work. He's engaging in activities. So really, we're not, he's not waking up hungover. He's not having withdrawal symptoms. So this is not alcohol use. Prescribe a zopiclone. Okay, so that may be something you do to help him sleep, but we have to get to the bottom of why this is going on because he's got symptoms other than difficulty sleeping. He's got mood lability. He's yelling at his wife. Okay, he's possibly having some conversion symptoms. So, conversion symptoms are where you've got physical symptoms that is related to a psychiatric illness, whether you know it or not. Okay, so that might be what's going on with body aches, and you treat the PTSD. If it's there, that might go away. Provide information about social support programs for veterans. Again, something you might do, but you need to figure out whether this is PTSD. Do we know it's PTSD based on this alone? No. Based on this information you have, it does not satisfy the criteria for PTSD. But here's the deal. When you've got a veteran, particularly a male veteran, they are not going to tell you they've got PTSD. There is a big stigma with mental health, particularly with men. And it has been my experience that patients who have PTSD downplay their symptoms. And people who come in saying, I have PTSD, often don't have it. Okay? That's not to say if they come in saying they've got PTSD, you ignore them and you don't screen them. But it is to say that patients with PTSD often downplay their symptoms, and that is exactly what's probably going on here. Look at, he says he doesn't want to talk about what happened during the war. Why would you not want to talk about it? Let's say he worked an office job during the war. He'd probably be okay with talking about it. He says, I don't want to talk about it. Something probably happened. Okay, maybe he saw someone die. Maybe he saw a comrade. Maybe he got almost got shot. Okay, so you would want to know that because if something like that happened, you're really thinking PTSD. Now, you should have a general idea of what PTSD looks like. I'm going to move on here. Look at this. There are tons of criteria, but just have a general idea. Okay, so intrusion symptoms. You need to have at least one. Intrusion symptoms is where you're having thoughts you don't want to have. So recurrent memories, recurrent dreams, very common, nightmares, dissociations, flashbacks. That is intrusive symptoms. So it's where you have thoughts that you don't want to have. Avoidance. So this is where you avoid reminders, whether they're internal or external. So internal, where you really try to suppress those memories. That is what he had. Okay, he had that. He didn't want to talk about the war. That is avoidance. Okay. External, you may avoid going back to the place where something happened. Okay, let's say you almost get hit by a car on Main Street and Elm Street intersection, and you avoid going there on your way to work, even though it takes you an extra 10 miles to drive there, drive to work. So that would be avoidance. Okay, so he's got this. As far as we know, we don't know of any intrusive symptoms. So he doesn't meet that yet. Negative cognition and mood. Let's see. So we're talking about amnesia here, exaggerated negative beliefs, distortion, negative emotional state, fear, horror, anger, guilt, shame, loss of interest, detachment, persistent loss of positive emotions. We don't know if he's got this. We need to do a little bit more digging here. Hyperarousal. So reckless, self-destructive behavior, angry outbursts. He's probably got at least one. So you can see here, we're meeting a decent number of criteria for PTSD, and we need to get to the bottom of whether this is what it is. You got a veteran with any criteria for PTSD, dig. Now, here's the deal. You've got a patient, you think they've got PTSD. They're a veteran, they're a male, particularly. They may not want to talk about it, but if you give them a questionnaire that they can fill out on paper or on a tablet, they may do that, okay? So maybe he doesn't want to talk about it, but he's okay with checking off which symptoms he's got. That's a great way to get to a patient because, a lot of times you don't want to talk about something. You don't want to talk about your depression. You don't want to talk about your anxiety. Maybe you're embarrassed. But if you give them a piece of paper to fill out, they may be more receptive to that. So here's a great way to go through PTSD and try to understand it. So you still need to know your symptom criteria, but as long as you know intrusion, avoidance, mood, and arousal, these questions will be pretty clear if they're asking you to diagnose PTSD. Really look at the nightmares, look at the avoidance, not wanting to drive certain places, looking for the outbursts, the low mood, the inability to be happy, sleep disturbances, and so forth. Okay, so there's got to be a traumatic event, and that traumatic event has got to be a physical threat to life and limb. Okay, so we're not talking about, you got broken up with and now you never want to go to where you had your first date. That is not PTSD. You got to be directly exposed to the trauma. It's got to either happen to you, or you have to have seen it, or you have to have learned of it. Okay, but it's got to be a threat to life and limb. That could be a death, it could be a serious injury or accident, or it could be sexual violence. Okay, so sexual assault. So that is PTSD. So you've got to have that first. Then there's got to be the exposure. So typically those two come together. They've got to meet the symptom criteria then. Okay, if they meet the symptom criteria, you are well on your way. But next, the duration has to be 1 month or more. So they have to have had these symptoms for at least a month. If they don't, if they're here and it's less than a month, what is it? Acute stress disorder. And if that persists then beyond a month, then it is PTSD. But PTSD has to be at least a month. And it's got to cause distress or impairment. Pretty much always does. I mean, if you're having to avoid things, you're having intrusive thoughts, you're not sleeping, that's going to cause impairment. At that point, and only that point, can you diagnose PTSD. Treatment for PTSD, you're treating comorbid disorders. Nightmares, you can really go a long way with... There are drugs like prazosin can help with nightmares. Really, really good drug. Just make sure, if they're older and they're on a beta blocker, you really don't want to use that. Maybe switch them from a beta blocker to a calcium channel blocker or an ACE inhibitor. You don't want to use an alpha blocker and a beta blocker. They'll fall over. They'll faint. It's going to cause an orthostatic hypotension. Okay, so. Prazosin may come up on your exam. If they're having panic attacks, you may go for a short-acting benzodiazepine, but do keep in mind that patients with PTSD are at risk for substance abuse. So you got to be very, very careful with that.